This podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each person is so unique, please consult with your healthcare professional for any medical questions that you may have.
Welcome, everyone. We're back for another episode of the Not Your Doc Pod. I'm your host, Vanessa, and we're here again today with Mr. Doc, not your doc himself, Dr. Charles Tadros. How are you doing, Dr. Tadros?
Hey, Vanessa. How are you? It's nice to hear your voice. Nice to see you, in fact. I'm not just listening to your voice. I'm looking at you.
Yeah. No, it's good to be here. Are you happy that it's fall today?
Yes, it is. It's a gorgeous day today.
It was like 96 degrees yesterday, and today it's like low 70s.
I was sitting in my car a couple of days ago. I'm like, why is it so hot? I kept looking at my air conditioner thinking it was broken, or I had, I wasn't recirculating the air, and then I realized, it's 100 degrees outside.
Yeah, literally. It's very in keeping with Missouri weather for it to be the actual first day of fall, and it feels like fall. Yesterday it felt like summer. So.
St. Louis weather. Yes. Hopefully we'll have some relatives over this Sunday.
Oh, nice. Mm-hmm. Okay. So today we're going to talk about the other primary condition that we treat the most at the clinic, and that is anxiety. Mm-hmm. So once again, we're going to try and demystify some things about anxiety by zooming the lens out and starting with the basics. If you are, as a listener, if you haven't already listened to our previous episode about depression, you may want to go back and listen to that first before listening to the rest of this episode. In it, Dr. Tadros covers a lot about the process of identifying and getting treatment for depression that also applies directly to treatment for anxiety, specifically the importance of ruling out medical causes with your primary care physician and then when to see a psychiatrist. Mm-hmm. So all of that being said, Dr. Tadros, let's talk first about the symptoms of anxiety before we talk about its clinical definition. So what does anxiety feel like? Physically, mentally, emotionally?
Well, I could probably ask anybody, and they could tell me pretty dang accurately. I think, almost everybody will have some sort of anxiousness throughout sometime in their life.
Yeah.
Anxiousness is a broad range, and we'll talk about the different categories of anxiety. But anxiety is just an excessive amount of worry that is probably out of proportion to the situation, and the key is that it lasts for significant enough time, oftentimes 6 months or more, and it impairs your functioning. So that's roughly just how to talk about it. But if we talk about generalized anxiety, GAD, looks like you should be happy because it looks like GAD, but it's a generalized anxiety. I'm GAD. Oh, yeah. But that's probably the most common. It's the chronic worrier, the worrywart, and it could be about stuff that they can control or can't control, anticipate about stuff that's going to happen in the future that they may not be able to control. But it's this chronic worry. It oftentimes shows up as an internal tension, brain whirling in terms of recurring thoughts and worries. Sometimes disturbed sleep. Sometimes it's occasionally disturbed appetite, irritability, and other things like that. That'll tell us about generalized anxiety. People get stressed all the time. People get other things sad that goes with stress. People feel out of control. People feel overwhelmed, and that's not always the clinical diagnosis of generalized anxiety. So the key is the length. Not only that it impairs your life, but that it's 6 months or more, and that's a long time to live with something like that.
Yeah, absolutely.
But that's enough for the doc to consider medication treatment. But let's talk more about that because it's not medication. In fact, the older doc I become, the more I think medication is helpful, but not enough by itself by any stretch.
Yeah. So we answered this you answered this question first when we talked about depression. But who gets anxious? Yeah. Is it a universally experienced
Right.
thing at some time or another in people's lives?
Yeah, generalized anxiety, it can be from kids all the way through older folk. In fact, I think we oftentimes miss it in kids, and we can come back to that because it may manifest in other ways. And then as I've gotten older with my patients, as they say, you grow old with your patients, is that we recognize that depression and especially anxiety kind of comes up late in life also.
Yeah, absolutely. And we'll talk more about how those tend to go hand in hand. So, how can you tell if those, persistent anxiety symptoms rise to the level of a clinical diagnosis? What's the clinical definition?
Yeah, so I'll talk about 5 major types of anxiety categories. There's some minor ones. We'll talk the minor ones. So the big ones we'll talk because people have heard these acronyms and these terms. So there's generalized anxiety, chronic worrywart. There's panic disorder. These are people that actually have physical symptoms. They feel like they're dying or going crazy. Then there's PTSD, post-traumatic stress disorder. These are people that either has something terrible has happened to them or could have happened to them, or somebody that they witnessed. So whether it's rape or they were in war or they were in an accident. Then there's phobias, social phobias. This is sometimes everything from fear of separation from your youth to fear of being in a public place with other people. So that covers, and then there's, so we've covered generalized anxiety, because I forget sometimes, generalized anxiety, generalized anxiety, panic, PTSD, social phobia, and then OCD, obsessive compulsive disorder, which is also a type of in the anxiety category. Now, some of the ones that we're not going to really cover much because we don't see too much of this is anxiety due to certain conditions. So anxiety due to drug use. So people who are using stimulants can get anxiety spells and symptoms. People on cocaine. And then there are people who have medical conditions, the hyperthyroidism, overactive thyroid. These people can have palpitations and weight loss and insomnia and diarrhea and stuff that mimics psychological anxiety, but there's a physical cause. Their thyroid is overactive. And hyperadrenalism, hypercorticolism, which is extra steroids. Your adrenal glands sits on top of your kidneys. Sometimes for a couple of different reasons, they'll make extra cortisol. Cortisol sounds like cortisone. Right. Cortisol is your body's own natural steroid, and that sometimes will cause you also to feel panicky. So those are the ones we won't talk so much about. Yeah.
So talk more about some of those physical manifestations of anxiety. I mean, I think we kind of get the mindset and the psychological factors that can cause us to feel it, but what are some of the physical symptoms as well?
So, like I said, for generalized anxiety, there's physical tension, sometimes muscular tension, sometimes you're clenching in your jaw, in your neck, your shoulders, back.
Tension.
Those are some of the things. And once again, you can have tension in your jaw for other reasons.
Sure.
So it's not exclusive to just to anxiety disorders. So emotional tension, sleep disturbance, difficulty dropping off to sleep. It's usually you pop awake. Typically dropping off is more common than popping awake. But for severe anxiety, we've seen people pop awake in the middle of the night and stuff like that. But difficulty dropping off because your mind is swirling with a bunch of ideas and worries and thoughts. So sometimes people will lose weight because they're stressed. They lost their appetite because they're so anxious. So that's the other thing. Irritability. So that sometimes shows up in kids, and that's where we sometimes misinterpret it. The kids that are oppositional defiant. Right. I think we have to consider they don't show up necessarily. They don't come to mom and dad say, "I'm worried, I'm anxious, I don't want to go to school." They just it
affects their behavior.
That's right. They become angry and throw things and stuff like that. Sure. So that's where I would kind of place kind of the physical symptoms for generalized anxiety.
Sure.
Panic, feel like you're going to die. Sometimes chest pains or shortness of breath. Feel like you're going to go crazy. You feel like you have to pace. You feel sometimes totally exhausted.
Hyperventilating, dissociation.
That's right. Yeah. Hyperventilating, which cause numbness in the fingers and lips and your head. Feels like it's going to pass out or dizzy. And dissociation is in more severe cases. That's correct.
Yeah.
So this feels like your out of body experience. So that's for the panic. For PTSD, we talk about flashbacks and nightmares. Flashbacks feels like you're back in that situation again, or whatever it was.
The threat's just as real as it was then.
That's right. Even if it's decades before, whether it's rape or you're in a battle or you're wounded or your buddy gets wounded right next to you, or in your car accident. So it's not just stuff that that did happen to you, could have happened to you,
right?
Or it happened to somebody that you knew. So we have to consider that. And sometimes there's something called complex PTSD, which is that you had it repeated. So if you were abused by a relative repeatedly, not just one time, just a one-time, but repeatedly over months to years, that's considered complex PTSD. And then OCD, obsessive compulsive disorder. There's obsessions, which are thoughts and beliefs, and then there's compulsions, the doing, the acting. It's easier to pick up the compulsions because whether it's rearranging things after somebody touches them to make sure that they're right, going back and checking something to make sure that the oven is off or the door is closed, thinking or washing your hands repeatedly to the point where you practically can't leave the bathroom and your hands are cracking and bleeding because you wash dozens of times per day.
Sure.
And that's the compulsions, that's the doing. And the compulsions are there to relieve the obsessions.
Right.
The obsessions, even though that you recognize that your hands are not dirty, right? You know that you don't have amnesia, you just wash your hands 5 times. But you feel like if you don't do the action, the anxiety will build up.
Right.
So the compulsions are to decrease your anxiety.
Right.
The problem is
it's a check.
Right, it's a check. And the problem is it feeds back into your mental state. So it doesn't relieve it. It's not like, okay, I've washed my hands 10, 12 times before I go to work in the morning. I should be clean now. It's that you can't. It feeds back into it. So that's and obsessions and it could be obsessions without compulsions.
Right.
You could just have recurring thoughts that you have cancer and that nobody's listening to you, nobody's paying attention, nobody cares, and so you keep thinking that you have cancer, or you get relief because you get a test or see a doc, you get a relief for a few hours or a few days, but then either you go back to that obsession about that cancer, or you start fixating on something else, obsessions about something else, about your health. Yeah.
So, that again, we were talking about depression. There's sort of like some people who are able to function with it and some people who just shut down completely. Like, what kind of functional effects do we see on people's lives who have anxiety?
Yeah, so some people can function despite significant anxiety. They have other personality and other features that help them, but it's exhausting. And once again, you'll hear me throughout our podcasts. Some people are not curled up in bed, quivering and shaking and dysfunctional, totally dysfunctional. They're able to power through it, but it's just exhausting to maintain the rest of your day, rest of your schedule, rest of your responsibilities.
Constant vigilance,
Right. So certainly anything that affects your life, you know that you need to cook, you need to go to school, you need to go to camp, you need to go teach, whatever it is. But it becomes very difficult. So some things are depression that prevents you from doing that, but things a lot of times it's anxiety. I had an adult patient. This is an adult, not a kid. He had such animosity at work and so much work-related tension. He started throwing up, Sunday night.
Yeah.
And it would,
literal Sunday scaries.
Yeah, right. Yeah. So and we went hunting because we see it in kids, but we went hunting for all sorts of GI and neurologic problems, and it was really his anxiety. He's just an obsessive and anxious, very anxious person, but he still powered through and made it to work a lot of times. But it's that physically debilitating, and to the point, and in fact, a lot of emergency room visits for chest pains and other things like that. A lot of them, fortunately, if we have 100 chest pain visits for middle-aged people, young and middle-aged people, fortunately, we don't have 100 people with heart attacks or 100 people with lung clots in their lung or something serious. A lot of stuff is GI and chest wall and anxiety. And
Panic.
anxiety uses up a lot of resources. poor patients and their families and the emergency rooms and all the other stuff that we have to do to prove that it's not something that's immediately life-threatening.
Yeah. So you kind of alluded to this, this kind of symbiotic relationship between depression and anxiety. Can you talk a little bit more about how easily those two things go hand in hand and sort of how they function together in relationship?
Yeah, probably 70% of our depressed people that are initially depressed eventually get anxiety on top of their depression, and eventually, and certainly if you're not undiagnosed anxious person, if you're primarily anxious and you're undiagnosed for months to years, oftentimes these people will become depressed.
Yeah,
it's because they just have to power through so much stuff. I remind patients who sometimes confuse the two. Depression, you feel low mood, sadness, decreased energy, decreased interest, loss of pleasure. Whereas anxiety, oftentimes you feel like you're going to crawl out of your skin.
Right.
You're worried. You're panicked. You have anticipation of bad things happening.
Yes.
And whether they do or don't, et cetera. In fact, that's one of the hallmarks for panic disorder is that you anticipate that you're going to have another panic disorder, a panic spell somewhere that's going to embarrass you or where you can't control it and can't get help.
Absolutely.
Yeah.
And I think another pattern that we see, and I've experienced this personally, is that the anxiety and the fear and the dread of completing a task or being in a situation that brings you those emotions and feelings, it's so overwhelming that the only possibility you can think of to alleviate that stress is just to cancel all of your obligations and responsibilities and completely let yourself off the hook. And then almost immediately that depression takes over, where you're self-loathing and judging yourself and and just so down and sad and in a low mood because you can't accomplish the things that you want to accomplish or set your mind to. And so it becomes kind of a self-feeding cycle.
So that's important. And conscientious people, they know what they need to do. Whether they go to school or get a project done or go to the kids' baseball game, whatever it is, they know what they're responsible for, but they can't do it, or they have a hard time doing it, or it comes at a great energy and a great expense, and then they don't get pleasure in doing it. Yeah. It's so much torture to get it done or get it started that they don't get the pleasure, they don't get the reward, they don't get the positive feedback, and oftentimes it's done late or done poorly, and so. They know that they could have done better or should have done better. So whether it's depression or anxiety, I know we're conflating the two right now. It's one of the things I'd like to talk to people. It's not enough to promise that you're going to do better tomorrow.
Yes. I
think it's important to have tools and sometimes medications, oftentimes medications to help break the cycle. But also the tools when your brain gets locked into anxiety about anticipating about starting a project or getting standing in front of a class or whatever it is, so you need tools, and that's one of the things that I talk to people about, and oftentimes they will not hear me, and they have to go through it several rounds before they believe that they need more help than just wishing a song and a prayer here, because that's what they like. I recognize what's happening to me. I know I need to get up early. I know I need to finish this task, this project. And it's not that they don't know. It's not that they're not aware. It's that literally they have mental and physical blocks that get stronger. They seem to get worse the more they push themselves.
Sure. And we're definitely going to talk about the role of behavior modification and therapy here with Treating Anxiety Minute. But let's start with just what kinds of treatments are available for anxiety in general. Let's talk medications.
Yeah. So for generalized anxiety, for all the anxiety, SSRIs. So we'll talk medications first, and that's oftentimes it's not the first. And although I talk because I'm a physician, I talk about medications first. But oftentimes there are psychosocial and lifestyle things that can be done, and certainly they should be added to medications. But sometimes it can be enough just to do those, talk therapy and some other things. They may be able, if it's mild to moderate depression, OCD, and stuff like that, you may be able to get away with that.
So patients should not take this in order of importance that we're discussing it. We're just going to, this was the format we used for depression, so we're just going to follow it here.
Thank you. Thanks for clarifying that. So, selective serotonin reuptake inhibitors are good for OCD, PTSD, generalized anxiety, and panic. So those are those are pretty good. And sometimes you have to use higher doses in order for the more severe panic and OCD and PTSD. So that's just, the first thing. Then SNRI, selective norepinephrine reuptake inhibitors. So the first ones, the SSRIs, are Prozac and Zoloft and Paxil and Celexa and Lexapro. The second SNRIs are the venlafaxine, the Effexors, and the Cymbaltas or duloxetines, and others. So oftentimes those are the first ones. As I mentioned, with depression, we have with severe OCD and with panic, we have clomipramine, and we have MAO inhibitors, monoamine oxidase inhibitors. These are older drugs that have more side effects. But sometimes, whenever the first line therapies like SSRIs, SNRIs are not working, we can go to older drugs that have more side effects, more potential for overdose if patients can overdose on them on purpose or accidentally. But they can be quite effective also. So those are those are the general classes. Occasionally, people will get atypical antipsychotics added onto some of these other medications if they have severe panic and OCD. But it turns out that cognitive behavioral therapy is probably excellent for all these types, whether generalized or panic or PTSD or OCD, PTSD, OCD, or social phobias. So it turns out cognitive behavioral and other types of exposure and response therapy, another type of therapy, it can also be extremely helpful. So these are not drugs. This is with a psychologist who does not prescribe or some sort of talk therapist.
Sure.
That's extremely important. This is where I talked about people need tools.
Yeah.
Whether you have pills or don't have pills, you still need tools. You need to understand where this stuff is coming from.
Right.
So
one thing I didn't hear in your list of treatments is benzodiazepines.
Yes. Yeah.
So I like your perspective on this, and I want to hear more about what your thoughts are, because I think a lot of people think, okay, I have anxiety, they're going to give me Valium, they're going to give me Klonopin, they're going to give me Xanax, something like that.
Yeah.
Talk about why those shouldn't be first line treatments, and the other issues that come up with benzo use, heavy benzo use.
Well, I grew up in the era, and the people who trained me grew up in the era where benzos were used heavily, and it got us into a lot of trouble. Even if we used them correctly, it got us into a lot of trouble. And so let's talk about the benzodiazepines. That's the Valiums, which are also called diazepams, the Klonopins or clonazepams, the Transines, the Xanaxes or alprazolam, the lorazepam or Ativans. These are all Valium products. So these are addictive and habit forming. Addiction means that if you try to stop them, you can have withdrawals, physical withdrawals. In fact, if you have higher doses and use them for longer periods of time, and especially if you mix them with alcohol, we'll come back to that. But benzodiazepines, if you're on moderate to higher doses and you try to stop them all at once, or you miss a dose or there's some doses, you could potentially have seizures and die. So that's one of the things that can happen. The other thing that's been shown more recently in the last few years is that chronic benzodiazepine use can be associated with increased risk for cognitive decline, dementias. So that's the other thing. If you have untreated sleep apnea, where you stop breathing at night already, and you put people on benzodiazepines, and oftentimes they're in the form of sleep aids, and we can get into that, you can worsen their sleep apnea, right? So they can become so sedated that they obstruct or stop breathing more with obstructive sleep apnea. One of the problems is that people get the tolerance to it, where they need more and more of it to get the same relaxing effect. It's not that they don't work; they work too well.
So well.
They work too well, and people don't want to come off of them. And whenever when the doctor tries to cut them off or taper them down, they have a rebound problem, and it's pretty marked. They don't go whenever you try to stop it. If you don't have a seizure, you don't go back to your usual anxiety. You go super anxious for sometimes multiple days to a couple of weeks before you can go back to your usual anxiety. So the problem is whenever patients run out of their drug or they become frustrated and angry because the doctor's not doing it, so they just they toss their pills. What people don't tell them is is that's one of the few, that and alcohol are the two things that you should not try to stop on your own.
Yeah.
You need the doctors to help guide you on this. So that's extremely important. The other piece that what happens accidentally is that people accidentally find out that if they take their Xanax and they take a slug, a little bit of liquor or beer or wine, that they feel better.
Yeah.
Not the Xanax.
That it works better.
The Xanax works, and maybe it works less and less. And instead of calling the doc for more Xanax, they just have a beer with it, and all of a sudden it works really well. And so this is what we call they are synergistic. They work together to give you the same effect.
Right.
And unfortunately, you get something called cross tolerance, where the more alcohol you have, the more tolerance you have for having Xanax. So that if you go to the emergency room and they try to give you a Valium to help you with whatever problem that you're having, they're going to have to give you fairly high doses because you're taking a little bit of Xanax at home with quite a bit of beer or wine, and then all of a sudden in the ER, whenever they try to give you some Valium products like your Xanax, you're going to have to use a higher dose, because you have something called cross tolerance, and so that becomes doubly problematic whenever you try to come off of one or both of them, is that you increase the risk of seizures and death whenever you try. So that's the other thing. If you're a moderate to heavy drinker, and we can talk about that in another podcast, even without Xanax, without any other benzos, coming off of alcohol is its own problem.
And say something about the risk of death associated with benzo and alcohol use together. You can feel relatively fine going to bed and go to sleep and just not wake up because it depresses your nervous system so much.
Yeah, and so this is instead of having to go to the doctor to treat your anxiety and get Xanax or Prozac or do talk therapy, some people just learn alcohol will help them with their anxiety.
Sure.
And the problem, like with Xanax, is that they need more and more of it over time to help them. So they whether they start at the end of the day, whenever they want to unwind after a rough day, and then they have a couple in the evening, and then they start expanding it more and more in their life. Sometimes it can go quickly in terms of weeks or months to expand to take over more and more of their life. And a lot of the stuff is not trying to get buzzed or high. They're just trying to calm themselves down from their rough day and stuff like that, and from their anxiety disorders. So a lot of people are not intentionally trying to do anything, but unfortunately the side effect is that they get into trouble. And the physicians, and I have that in one of my blogs, the physicians don't recognize it. They don't ask enough questions. They misinterpret what the patient says. They don't drill down deep farther. And this is even still happens to me today. The patients say, I don't drink that much. Well, it turns out they don't drink that much because they stopped 5 days ago because they knew they're going to come see me. Yeah. And so when 4 or 5 days ago, their benzos or the alcohol was moderate to high and stuff like that. So you have to drill down, and sometimes you have to make statements such as, okay, you may not want to share everything, but this is what I worry about. So you have to tell them some potential side effects so they can weigh that stuff for themselves. But anyway, but people learn to self-medicate. Sure. And so that's another thing. We can talk about marijuana separately another day. But certainly probably the most dangerous drugs out there combined are over alcohol that you don't need a prescription for, and benzos that you need a prescription for.
Absolutely.
And people just are trying to feel better. They're trying to get to sleep. They're trying to be less nervous. They're trying to be happier at a party, whatever it is.
Yeah, absolutely. Very, very, very dangerous. So now we've talked about some of the drug treatments for anxiety. Now let's definitely talk about therapy. So in my personal experience, like behavioral coping skills that I've learned in therapy have been incredibly important for managing my anxiety. And I find that those skills and tools have actually been more helpful for managing my anxiety than for managing my depression. And I'm sure there are plenty of reasons for that. But why are those tools so important? I think specifically emotional intelligence, being able to name and describe the feelings that you're having. Yes. And then also behavior modifications and coping skills to manage those emotions that you're experiencing. Why are they such an important and critical component to treating anxiety?
Well, so it turns out there's something called neuroplasticity. So we can retrain our brain. If you want to learn how to learn a new language or learn how to play a violin or anything in life, you're laying down new tracks, new pathways in your nervous system. And just the same way by through whether types of talk therapy or exposure therapy, you're laying down new tracks. Now you don't get rid of the old tracks. You don't get rid of the old traumas and the old stuff, but you can quiet them down. by using some of the new habits that you train. You're going to practice. You're going to train. You're going to be exposed. You're going to expose yourself. You're going to expose yourself with the help of a therapist and stuff like that. And eventually, you'll learn exposure for yourself. And so you're laying down new pathways that help mitigate some of the effects of the anxiety disorders.
Yeah, absolutely. I think too, especially with starting with naming emotions and being able to say, because I think sometimes people say, well, I'm depressed or I'm anxious. And it's very general. Do you feel tightness in your chest? Are you exhausted? Are you irritable? Are you crying? Like there are a lot more specific things that you can be experiencing physically or emotionally that you need to be able to name in order to pick the right coping skill that's going to help you mitigate those things that you're experiencing.
That's right. We haven't touched on this. You can get your doctorate degree in childhood trauma and other things that happen in childhood. But a lot of stuff we can trace back, not always, but a lot of stuff we can trace back to abandonment and trauma, or perceived abandonment and trauma, even if the loved ones, your relatives were there taking care of you, if they were busy doing other things too, and so perceived and not only just real, and abuse also. So abandonment, abuse, and trauma are big deals in childhood that we later see in life as depression, anxiety, and all sorts of other issues that affect your work and your love life, etc. But naming, putting a name to your symptoms, your palpitations, your fatigue, if you slept long enough and stuff like that. Naming is extremely important. Otherwise, it's just this gray fog that you're trying to fight.
It's so nebulous.
It's like all over. So this is out in the ether. Everything bothers you. Everything's scary. Right. So to actually be able to kind of put a wall around it and be able to name it, that it's this is my childhood sense of abandonment now. I feel it this way as an adult. Oftentimes is a humongous help. And sometimes we can't get rid of all your symptoms with medicines, but what we can do is give you so much insight that they don't last very long, because you can catch yourself, and you can cut it off at the pass much more quickly before you may have hours of symptoms and some days of worries. Now you can catch it much more, and you get practiced and you get better at it. And this is without even medications. Right. Yeah.
So you mentioned cognitive behavioral therapy before. What kinds of behavioral therapies are effective in treating anxiety?
Yeah, so certainly CBT, cognitive behavioral. So this is the type. This is whenever you, what the therapist will do is work with you how you're thinking, or your thoughts and beliefs now, your perceptions now of whatever the troubles that somebody doesn't like you, or your physical symptoms. Help you question and reframe. I'm anxious that my kid is at the side of the road and must be dead because they didn't return my call. What other things could be happening with your child? It's like their phone could be dead. They could be having too much good time at the party. They may, So what's more likely, that they're dead at the side of the road, or is it more likely that they're not listening to their phone because they're with friends?
That helps deal with that mismatch that you explained at the beginning. That this is worry that is out of proportion to what reality is.
Right. Yeah. Yeah, and some things are it's not unusual to worry about your kids, or worry about cancer, or worry, there's a lot. Most of these worries are very realistic. It's just way out of proportion, and they last much longer than the reassurance. Once you're reassured that the kid is but you're still panicking, you're still shaking, you're still worrying about the next time that the kid doesn't respond to your call or your text. So that's it's not that these people are grabbing things out of left field. These are real. The vast majority, for some of them are, but the vast majority are real concerns about money, about relationships, but it's just
about things that should be worried about.
That's right.
Really,
but should be contained.
Yes.
That should not swallow up your whole life and all your energy.
Absolutely. Okay, so CBT. What else do we have for anxiety?
But exposure and response. The other one, the other big one that I like is for exposure and response therapy. That for oftentimes for our PTSD patients and our people with social phobias. Fear of speaking, fear of being out in public, fear of meeting strangers, new people, and stuff like that. So that's the other other type. And there's another group that's not as well studied for this, but dialectical behavioral therapy also can be helpful. Dialectical behavioral therapy was initially developed for personality disorders, borderline personalities, but now it's been modified to include depression and anxiety for certain people.
Yeah.
So that can be helpful. And there's many types of therapies out there, and even I, as a physician, as a primary care physician, I don't always know what kind of therapies. And usually, most practitioners do several types of therapy.
Right.
They know several types of techniques. They don't just use one. So whenever I send a patient to a therapist or ask them to go find a therapist, I'm not always sure what type of therapy they're going to get. But I want patients to be aware to ask and say, hey, what are we going to do? There's EMDR, the eye movement, I can't even remember it as eye movement desensitization and reprogramming.
Yeah.
So this is used for PTSD initially, and now they do it for other depression, anxiety. So
let's give an example for people to tell people understand exposure therapy, because I think that could have a really great application. So say I get extremely anxious and worked up when I know I have to drive on the highway. What would exposure therapy look like to help me overcome something like that?
So the therapist will be interested in knowing kind of what kind of historical problems you've had about driving. If you had an accident, or you were a kid and your parents were driving, or you witnessed an accident, so they want to know kind of where things may have started. You may not always know, and then you'll describe to them what you feel. It's like, even thinking about getting into the car makes me panicked and stuff like that. So I don't even want to think about it. Well, what we're going to do is start showing you pictures of a car. So we won't even get you out in the, we're going to show you pictures of a car, and we'll monitor you. We'll monitor your pulse and your sweats and what your racing thoughts. And we're going to give you techniques to help you calm you so that you can deal with the physical symptoms first. So your racing thoughts, can you think about, more pleasant things that are happening? Your racing, breathing techniques and other things like that, meditation techniques, so that you can have tools to control your anxiety. Sometimes you have pills like beta blockers and other things, but these are tools. This is a therapist. Yeah. And so, okay, if we get to the point where you can look at a picture of a car or think about a car, the next thing we're going to get you out to the garage or the driveway and look at the car physically itself, and then we use that. And sometimes this can be done over several hours. Sometimes it goes over days, but sometimes over several hours. Then we're going to sit in the car. Then we're going to turn on the car and just sit in the driveway. Then we're going to have you pull out of the driveway and just drive down the street in your own familiar neighborhood and come back.
And the goal of taking this stepwise is for me to identify what I'm experiencing physically and emotionally as I'm getting progressively closer to to this stressor, and practicing using those tools to calm myself again. That's right. And then once I'm calm in a previously stressful environment, we're ready to escalate things a little bit closer to.
And thanks for clarifying that, because that's extremely important. Your memory is the memory of or the fear is associated with physical symptoms and psychological symptoms. So your memory of a bad car trip or a bad accident is so now that you're safe, gotta be safe. Just the memory, even months and years later, can trigger those physical and psychological symptoms. What we're trying to do is dissociate the memory from the physical and psychological, so you can think about it and not have panic, and you can deal with actually using a car now and getting on a highway or getting on a back street. And that's kind of, so you stepwise through through the course. And sometimes you can do this all within a day, literally. And stuff that's bothered people for years, you can sometimes just step through with the help of and this is actually where a therapist oftentimes will have to leave the office and come, whether you're afraid of heights. They work with you on elevators or stairs or tall buildings. They'll come with you to a tall building and work with you up there. Same thing with PTSD people who are hypervigilant. These are people who are always watching their back. They'll work with you on being in crowds and open spaces and places that maybe at wartime were dangerous, or places that you were very worried about for your own safety.
I think the concept and therapeutic practice of desensitization is extremely powerful, and especially teaching people the process of becoming desensitized to something. So maybe you overcome this giant fear of being in the car. on the highway because you've walked through this process and you've realized, how to name how you're feeling and explain your emotions and what's going on in your body, calming yourself with your new tools, moving forward. You can apply that to so many other things that bring you anxiety or fear in your life. I think that's a really powerful one for people to look into.
There's something called microtraumas. These are not big enough to be called PTSD and stuff like that. Having to face your teacher whenever you got a bad grade and having to argue a question and, you felt that you were under their thumb and couldn't speak your mind, and that traumatized you with authority and stuff like that. And you could work with that even for microtraumas. Yeah, absolutely.
Okay, so let's talk now about treatment-resistant anxiety, because that's sort of where we wrapped things with depression as well. What's the clinical definition, or when does treated anxiety rise to the level of treatment-resistant, and what treatments are available?
Once again, there's resistant generalized anxiety and panic and PTSD and OCD and social anxiety. So they're going to be treated differently. But certainly if you've had several different rounds of therapy, whether oral medications or behavioral techniques that don't help or don't get you or you relapse, or you have too many side effects from the medications, for instance, like that, and the anxiety is still impacting your life. It's hard for you to get through your day. Then we can consider it treatment resistant. And for those patients, there's everything from ketamine to TMS, transcranial magnetic stimulation, sometimes in combination with your medication, other medications, oral medications, and we can go all the way to. Sometimes people having to have ECT for severe cases of OCD, for instance, and stuff like that, not for the other ones. So those are very special, and those are those need to go to psychiatrists, sometimes psychiatrists who specialize just in OCD and stuff like that, because it's so time consuming.
Yeah, absolutely. So let's kind of finish up with some lifestyle aspects that you think will help people reduce anxiety overall. I think that anxiety, like I was saying, just from personal experience, that I've found tools and lifestyle changes to be incredibly powerful in managing my anxiety, even more so than depression symptoms. So what can people do to influence just their, without doing meds, without doing therapy, what can they do now to help with their anxiety symptoms?
So something we didn't talk about is exercise and meditation. So whether it's yoga or breath exercises are extremely important and can be very helpful.
That's practice calming the nervous system, right? I mean, really just self-soothing.
That's correct. It's healthful ways to self-soothe. So meditation, including prayer, which is a form of meditation, can do it. Exercise can do it. Typically aerobic exercise, the swimming, jogging, biking, skipping rope, etc., can all be helpful. A lot of it eventually focuses around decreasing the sympathetic or flight, fight, or freeze response. So we're trying to decrease the sympathetic nervous system response. We can do it with medications, but you can do it also with breathing exercises, yoga, etc., and also with exercise. So I know exercise increases your respiratory rate, increases your heart rate, but it's appropriate for the demand of oxygen demand for your muscles and stuff like that. But afterwards, it also helps whenever you're at the recovery and afterwards that your resting is more restful. More restful. Your heart rate is lower than baseline.
And exercise kind of gives you an outlet for some of that restless energy, some of that undirected energy that can feel pent up as anxiety. You can expend some of that, and talk a little bit about alcohol too, and how alcohol can influence anxiety. I know that many people experience intense anxiety during a hangover when their body is going through that withdrawal process from alcohol. So how can, limiting or reducing your alcohol intake and, help with anxiety?
A lot of times there's a lot of shame around it if it's in front of a doc or family members and stuff like that. So I ask people, this is when alcohol is taking too much of your life. I ask people, do you feel embarrassed or angry if somebody brings up your drinking? Do you feel do you feel like you have to, now or in the past, do you have to feel like you need to cut down or cut out your alcohol even for a little while? People, take they take a month off of alcohol and just to show, to reset their body, et cetera. Do you feel like you have to get up in the morning to get an eye opener, to help with your hangover? You can take an aspirin or you can drink again.
Hair of the dog.
So that's the other thing. So any of these things, do you feel like you're missing? And so the craving is a kind of a missing. It's like I've chosen. Nobody told me to do it, but I've chosen to come off it. But I'm looking for it. I'm going to be off it for a week, or I'm looking forward to getting back to it and stuff like that. So the craving is stuff like that. You kind of think about it. It takes up more and more of your brain space to think about when your next drink is, whether it's a week from now or tonight or whatever. It's like that. So those are kind of signs for me that alcohol may be a significant problem in your life. And a lot of people are like I said, a lot of people, maybe young people are trying to get buzzed, hurry up and hit the Everclear to get buzzed as fast as possible. But most people, adults like us, what they do is slip into habits. Yeah. There's Zinfandel, their white wine, in the afternoon, whenever you don't have, the kids are gone or, you're semi-retired or fully retired, then you can start drinking earlier. What happens is if you have to go to work and stuff, you can start drinking earlier and earlier. And there's literally, as long as you're not driving, people say, well,
no reason to stop.
No reason. No, why, and it gets us into trouble health-wise. So I'm the one, as a physician, has to hear about the weight gain and the erection problems and the sleep disturbances and the triglyceride. I look at the triglyceride problems and the liver function problems, et cetera. So I'm the one that says, hey, I think that it may be your alcohol. Yeah. But a lot of people are self-medicating and they don't realize it. And whenever they try to cut back, they have worsening sleep because alcohol initially helps you sleep. Yeah. But then as soon as it wears off at 2:00 in the morning, you're wide awake.
And you feel horrible.
So you're wide awake, and because your sleeping aid, your nightcap, just wore off, and so it's hard to get back to sleep. And so and it takes a while to get back to your normal rhythms. It's not just a few days off of alcohol. So anyway,
Okay, well, I think we should kind of cap with what the future of anxiety treatment is like. I mean, I think we should start by saying that there are good treatments available for anxiety. Already. That's correct.
We have some very good, and a lot of them are not pills, not the SSRIs and SNRIs and stuff like that. But certainly whenever people need to get a handle on panic and stuff like that and OCD, sometimes they need medications up front until they get the tools, because it takes a while to get the tools.
Sure. You have to acquire them.
Practiced. Yes. One of the problems that therapists have is that when people are on medicines, especially benzos and alcohol, that if they're feeling good, they don't want to come.
Right, exactly.
They don't want to come learn any tools. They already feel fine.
My pill works.
Yeah, my pill works. My Ambien to help me sleep and stuff like that works and stuff like that. So that's part of the problem we run into. But certainly in the future, we're especially for PTSD and stuff like that, we're having psilocybin, magic mushrooms, and potentially MDMA and some other ones that right now are being studied for PTSD and for depression are potentially going to help people with anxiety disorders also. We'll see. So that's somewhere in the future. Ketamine, we certainly use that in our clinic for people with OCD and PTSD and anxiety disorders. Oftentimes they're already on medications that are somewhat helping. And so these patients come to us already with psychiatrists or primary care doctors already prescribing their oral medications. I tend to find, and you've heard me say dozens of times, a lot of people need therapy or more therapy or better therapy.
Yes.
They need better tools, better techniques. They need to stick it out longer, and stuff like that. Even if they don't think the therapy is helping, it takes practice in order for the neuroplasticity to stick.
Yeah, for sure. And okay, so we'll kind of summarize with kind of where we ended with depression as well. That the first step, if you're experiencing symptoms of anxiety or you feel like you might have anxiety that needs to be addressed by your doctor, start with your primary care physician to rule out any of those medical causes that Dr. Tadros was talking about first, to see if those things are possibly causing your anxiety. Be honest and open about how you're feeling with your doctor, taking care to name specifically what situation medications cause you anxiety, and what the symptoms of anxiety look like for you personally. And then also, take heart that there are lots of good treatment options out there for anxiety. There are many medications that work effectively, but specifically different behavioral therapies can be incredibly effective in helping people manage their different states of anxiety.
I will argue that you sometimes have to direct your physician that I don't want Xanax, I don't want this, that I would, and my mom takes Lexapro, and I'd rather, I don't want that, but I do want talk therapy, or I need a talk therapist, or my drinking, maybe, I think I'm masking my insomnia and my anxiety with drinking. I may need some help with that. So sometimes you have to tell your physician that you recognize that there are other treatments that they can reach for that are easy for them to reach for, but that you're wanting this path, or maybe simultaneously you want 2 or 3 things happening at once. You want a limited run of certain medications, but that you really want to work on the tools and other techniques.
Absolutely. So there's definitely hope out there. Of course, new treatments coming that we're really excited about for OCD, PTSD, lots of promising things on the psychedelic forefront there.
Yes.
And so if you want to tell us more about your experience with anxiety, or if you have other questions that have popped up as a result of this podcast, please reach out to us. You can send us an email at notyourdocpod@gmail.com. That is notyourdocpod@gmail.com. Thank you so much, Dr. Tadros.
It was fun. Thank you. Thanks for getting all the good questions I think that our listeners would like would have been here to talk about.
Absolutely. And we could do 10 more episodes about anxiety and therapies for anxiety. So stay tuned. There's 10 more.
Thanks.
Thanks. We'll see you all again.
All right. Bye-bye.